Bismillahir Rahmanir Rahim. This is Dr. Muhammad Jawad from Nephrology Nursing Program at High Institute for Health Specialties. You are welcome in our lecture Hemodialysis Adequacy. Definition. Dialysis adequacy is defined as the minimum amount of urea clearance and nutritional intake that prevents adverse outcomes. Adequacy of dialysis refers to how well we remove toxins and waste products from patients' blood and has a major impact on their well-being. The clinical aspect of dialysis adequacy: height and weight gain, control of anemia and acidosis, control of bone disease, control of blood pressure, relief of uremic symptoms, improve quality of life and life expectancy. The measurement depends on the small solute clearance, either by urea kinetic modeling, KTV, or urea reduction ratio. How do we know if a patient is adequately dialyzed? The National Cooperative Dialysis Study established urea kinetic modeling as the accepted method of measuring small solute clearance. The clearance of urea has been selected as the basis for all the calculations of dialysis adequacy. Why urea? Because it is small molecular weight, nearly 60 Dalton, and it is slightly toxic substances. It is regarded as a marker for small toxins removal. Urea clearance factors. It depends on the coefficient of dialyzer, pre- and post-treatment blood urea, the treatment time, the total body water, the urea ultrafiltration rate, residual renal function, and the interdialytic urea generation rate. Urea kinetic modeling, when calculations of dialysis adequacy use both urea clearance and patient's nutritional status. It is called urea kinetic modeling. It takes into account residual renal function, predicted dialyzer clearance, body and dialysate flow, time on dialysis, and fluid removal. It is not commonly used because of its complexity. The other measures of dialysis adequacy, either urea reduction ratio or single pool KTV, or equilibrated double pool KTV, or standardized KTV. In urea reduction ratio, it is calculated as follows: pre-dialysis urea minus post-dialysis urea on pre-dialysis urea by 100. It is simple reduction of mortality. Its limitation does not account for the contribution of ultrafiltration to dialysis dose. What is KTV? Fractional urea clearance. K is the clearance, dialyzer clearance, mil per minute or liter per hour. T, time of dialysis treatment. V, distribution volume of urea, mil or hour. K stands for the dialyzer clearance, the rate at which blood passes through the dialyzer, expressed in millimeters per minute. KT, the top part of the fraction, is clearance multiplied by time, representing the volume of fluid completely cleared of urea during a single treatment. Example: if the dialyzer's clearance is 300 ml and dialysis session lasts for 180 minutes, means 3 hours, KT will be 300 ml per minute multiplied by 180 minutes. The result comes to 54,000 ml or 54 liters. The body is about 60% water by weight. If patients weigh 70 kg or 154 pounds, volume will be 42 liters. So the ratio K multiplied by T to volume, or KT on V, compares the amount of fluid that passes through the dialyzer with the amount of fluid in patient's body. The KT on V for patients would be 1.3. KT on V, either single pool or equilibrated double pool or standardized KTV. In single pool, it assumes that the end of dialysis, the concentration of intracellular and extracellular urea ratio are equal. What is the difference between single pool and double pool? In single pool does not account for urea transfer between fluid compartment. With a high dialyzer clearance, urea removed from extracellular compartment and can exceed transfer from the intracellular compartment. Urea rebound 30 to 60 minutes, so dialysis dose will be overestimated if this urea pool is large. In equilibrated, KTV is 0.2 unit less than single pool, but it can be as great 0.6 unit less. Urea rebound is nearly complete in 15 minutes after hemodialysis, but may require up to 50 to 60 minutes. The degree of rebound is high in small patients, and this is the equations for calculations rebound for arterial access or venous access. Standardized KTV. The so-called standardized KTV urea grow out of the desire to produce a measure of hemodialysis adequacy that was not dependent on a number of treatments per week, and to have a measure where the minimum dose of hemodialysis would be like the minimum dose for peritoneal dialysis. The minimum dose urea reduction ratio more than 65% in single pool, 1.2 in the United States, and equilibrated pool 1.2 in European countries, and the standardized KTV 2. Clearance of other molecules. Middle molecules clearance thought to be important to prevent the long-term complications of dialysis. Beta-2 microglobulin is the most used marker. Phosphate clearance is also important and appears to correlate more with the hours of dialysis than rate of small molecular clearance. Normalized protein catabolic rate, a measure of urea generation which reflects nutritional status. Urea generation will broadly reflect protein intake. It is felt that patients require normalized protein catabolic rate 1 per kg per day. Normalized protein catabolic rate less than 0.8 gram per kg per day is associated with a higher mortality. Nutritional targets. Serum albumin should be more than 35 gram per liter. Normalized protein catabolic rate should be 1 per kg per day. Acceptable anthropometric measures. Residual renal function. When hemodialysis is first commenced, residual renal functions may contribute greatly to the total amount of solute clearance. This is usually calculated with a 24-hour urine collection. Residual renal function tends to diminish and reduce quickly on hemodialysis treatment. Errors of incorrect blood sampling. If sample is contaminated by blood from the dialyzer or heparin, or if there is recirculation, the urea result will be underestimated, giving a falsely high KTV. The earlier the blood is drawn after the completion of the dialysis, the higher the apparent delivered dose, as urea rises rapidly post-dialysis. Method of standardization of post-dialysis sampling. Stop dialysate flow is the most commonly used but gives higher result. Stop dialysate flow method. Stop dialysate flow but keep blood pump running for 5 minutes. Take sample from anywhere in the circuit. KTV. In the UK and USA, guidelines suggest a single pool KTV more than 1.2 for patients dialyzed 3 times per week, equating to urea reduction ratio of nearly 65%. Residual renal function should always be taken into account. Causes of inadequate dialysis. Improper dialysis prescription, inadequate blood flow, reduction in treatment time, dialyzer clotting and leaks, recirculation. How to improve clearance? Improve vascular access. If flows are poor or if there is excess recirculation, it will be hard to improve clearance. Increase blood flow, large needles. Increase dialyzer size, modest impact. Increase dialysate flow, increase dialysis time, frequency, major benefit, and consider hemodiafiltration. Note: measures of adequacy in children have not been defined, but consensus standards propose that they should be equal to or better than adult recommendations of more 1.2 for KTV and more 65% for urea reduction ratio. In conclusion, dialysis can be considered adequate if provides relief of uremic symptoms and control acidosis, control of blood pressure, correction of anemia, fluid and electrolyte balance, feeling of physical and psychological well-being. Thank you so much, and I am looking for your questions. I hope to meet in the next online lecture. Thank you again.